Thank you, everybody, for joining tonight. We'll be getting started in just a moment. All right, so good evening and welcome to this panel discussion hosted by Oncology Data Advisor and the VHL Alliance in honor of VHL Awareness Month. We have an exciting discussion in store for tonight on navigating the spectrum of VHL care, including advances, genetics, and patient perspectives. Our panelists tonight are Dr. Eric Jonasch, Professor of Medicine, Donika Saporito, Certified Genetic Counselor, and Kathy Clifford, VHL Patient Advocate. If anybody has any questions for our panelists, feel free to type them into the chat and we'll have some time to answer them throughout the discussion and at the end. And with that, I will turn it over to Dr. Jonasch to start the introductions and dive into the discussion.
Great. Thank you so much. And thank you all for being here. And in particular, thank you for Kathy and Donika joining us tonight for this, what I think is going to be a really robust and exciting discussion. First, we're going to introduce ourselves. So I'm Dr. Eric Jonasch. I'm a physician at MD Anderson Cancer Center, and I've been involved in the care of individuals with VHL disease for over 20 years. I've been involved in a number of drug studies that I'm going to talk about, and most recently the development of Belzutifan, which is being used by a number of individuals, probably even on the call. So next, I'd like to introduce Donika Saporito. And Donika, why don't you tell us a little bit about yourself?
Yeah, sure. I'm really glad to be here as well. My name's Donika, and I'm one of the genetic counselors at MD Anderson. And I get to work in the GU Center to see patients who have hereditary predispositions to different genitourinary conditions and indications. And so also in that realm falls VHL. So I have the opportunity to meet with other individuals affected with VHL as well. Have been here not quite as long as Dr. Jonasch, but it feels like a good amount of time. So have the opportunity to work with Dr. Jonasch and a lot of other incredible physicians. And we also have Kathy here, who's one of our patient advocates. Kathy, I'll let you go on and introduce yourself.
Hello, everybody. I'm glad I could be here tonight. I'm Kathy from Cheyenne, Wyoming, and I've been living with von Hippel-Lindau disease now for 30 years. I've been on Belzutifan, one of the drugs we're going to discuss tonight, for 3 years now. And I've experienced every aspect of VHL except the adrenal gland tumors. It's just easier to say it that way. So, but all the rest of it, I have quite a bit of experience with, unfortunately. So, and back to Dr. Johannes.
Great. Yeah, thank you both for those introductions, and just a little bit of an overview of what we're going to be talking about this evening. I'm going to talk about systemic therapies, and obviously the one that we're using mostly is Belzutifan, and I'm going to talk about when we should be using it, and talk about the side effects that we expect, and also how to manage those. Donika's then going to talk about genetic testing and counseling, and the role of genetic testing and counseling, and the role of the genetic counselor in individuals living with VHL. And lastly, then Kathy's going to talk about her perspective as a VHL a person living with VHL, and her journey. So I'll start then talking about systemic therapies. One of the things that we say is that we're curing cancer through VHL, because there's a lot that we learn about VHL from VHL that really, I think, applies to other cancers, and what the VHL community has offered to the world is really, I think, incredible and incredibly valuable and irreplaceable. when this gene was discovered in 1993, and a lot of research was done, and ultimately one of the Nobel Prizes for physiology or medicine was awarded in 2019 because of the work that was done on VHL. And out of that has arisen a number of therapies that have been very helpful for quite a few people with cancer. These include these targeted agents, drugs like sunitinib or Sutent, Votrient or pazopanib, and other so-called TKIs. And back in the day when those started becoming available for individuals with advanced renal cell carcinoma, with kidney cancer who didn't have VHL disease, we started trying those for individuals with VHL as well. And it was kind of interesting. They did do something. They resulted in some shrinkage, in particular in renal cancers, but the side effects were such that a lot of individuals who were on these trials, and we ran quite a few of them at MD Anderson, said, I'd rather have the surgery. I don't like the way I feel on these, and I don't want this as a long-term solution for my my treatment. So along comes Belzutifan, which once again, this lineage from the discovery of the gene, the VHL Alliance being incredibly important actually in the development of this as well, and helping getting patients to get on the studies and also pushing the research throughout the years. This drug was originally actually developed at the UT Southwestern in Dallas, and then this compound or precursor compounds were then basically developed. A company was formed called Peloton. The clinical trial was started, and then because it was looking very promising, Merck bought Peloton. And in 2021, we then got the approval for the use of Belzutifan in individuals with VHL disease. And what was really exciting was that we were given the approval to use this not only for renal cell carcinomas, which is what the study was originally designed to do. Basically, it was testing whether or not we could shrink the renal tumors consistently, and we could. But when the trial was being developed, we said to the company, we really need to make sure we capture information on hemangioblastomas and on pancreatic neuroendocrine tumors, just in case it looks like it's going to work there. Maybe we can use those data to expand the size of the trial, do another trial or something like that. And lo and behold, A, that was done. The information was gathered. But B, the information was so good that the FDA, the Food and Drug Administration, actually granted approval for Belzutifan in the treatment of VHL disease-related renal cell carcinomas, pancreatic neuroendocrine tumors, and hemangioblastomas. So what we're seeing that given, let's say every 100 people that we're treating with VHL who get Belzutifan, we're seeing that around 50% or so or greater, 67% or so of individuals now are having at least 30% shrinkage of their kidney tumors. And very few people, at least initially, have growth. But basically, very few people will have tumors just continue growing if you start the drug in the kidney, so which is kind of nice. And that's called progressive disease as best response. So the progressive disease as best response rate is like basically zero, which is great. Because that way you're not putting people at risk if you're trying. In the worst case scenario, things will be stable, and the majority of people you'll see shrinkage. Hemangioblastomas, when we were using things like pazopanib and sunitinib for the treatment of individuals with VHL, we were seeing that we were getting some very minor shrinkages with sunitinib and then a little bit more with pazopanib, but nothing super amazing. But with Belzutifan now in the treatment of individuals who have hemangioblastomas, we're seeing about 50% of people are having at least 30% shrinkage. And then in terms of how many people have this work not at all, it's very few. It's like 4% or so where their hemangioblastomas are going to grow despite the treatment. So once again, we're seeing that consistently hemangioblastomas, things are shrinking as well. Same with pancreatic neuroendocrine tumors. Actually, in the pancreas, you can get cysts, you can get serous cystadenomas, both of which are non-cancerous. And then you can get these pancreatic neuroendocrine tumors, which are bona fide cancers, and we have to watch out for those. And we're seeing here an incredible 91% of patients will see at least 30% shrinkage. And the shrinkages are actually quite a bit more. They're very profound in these pancreatic neuroendocrine tumors. So the two cancers that we get, the renal cell carcinomas and the pancreatic neuroendocrine tumors, we're seeing robust shrinkage. The hemangioblastomas, which probably are the worst, the most challenging manifestation that individuals with VHL will get. We're seeing 50% of them getting some benefit. So that all sounds wonderful, but of course, for every treatment you have, you're going to have side effects and issues. And there's three main side effects. One is fatigue. It's just whatever the cause is, and whether it's an indirect or direct cause, there's no question there's a subgroup of individuals who definitely get fatigue. The other thing it can do is it can cause anemia. And this is a fairly frequent, and it's because of the way the drug is designed. What it does is it basically blocks HIF-2 alpha, which is a transcription factor, which is a protein that basically goes into the nucleus and tells the cell, hey, we need to make more of this, that, and the other. And one of the things that is being ordered to do is to make something called epoerythropoietin, which makes the red blood cell count go up. So you block HIF, and you're going to get low EPO, and you're going to get anemia. So it's something that we kind of expect, but you have to deal with it, and that in of itself can cause fatigue. And the last thing that we see also is, especially in individuals who are getting a little bit older, let's say the 30-year-olds probably we're not seeing this as much with them, but in the 40, 50, and 60-year-olds, we're seeing hypoxia, meaning low oxygen levels. It's not super dangerous. We see it go down very rarely. We do see some individuals where it's a problem. And there might be some people in the call going, oh yeah, this was a problem. So yes, okay, it could be a problem, but the drug sticks around. Basically half of the level of the drug drops in about 24 hours. So if an individual, what we do is we tell everybody who starts on Belzutifan, buy a pulse oximeter. If you have an Amazon account, you can get one for less than $20 or $15. Maybe they're going to go up in the meantime, who knows? But you buy one of those, you check your oxygen saturation every day, and you adjust. If you start seeing your oxygen saturation go down, you hold. So and the last thing is the fatigue. And the fatigue, if we fix the anemia and we fix the hypoxia, still some people will get fatigue. So I'd say, this is not perfect. I'd say there's about a third of people who really don't like being on the drug and who say, thank you, Dr. Jonasch, I'm glad I tried this, but I just don't like the way I feel. I don't want to continue on this. Third are on it, they have side effects, but there's shrinkage, and they're like, okay, considering all of my options here, which would be potentially have to have surgery or ablation or something like that, this is okay. And your body also learns to live with these side effects over time. And then there's about a third where there's, you have your cake and eat it too. You get shrinkage and you get great quality of life. And we never know ahead of time who's going to be in which third. And so, at the end of the day, it's try it. If it's something that works for you, great. If not, we move on, because not everything is good for everybody. So I'm happy to answer questions. And there's a question from Seth Horowitz here. If patients are having side effects from Belzutifan impacting the quality of life but showing clinical SF, how quickly are you going to reduce the dosage? If this is going to be something that a person's going to be on for years, you've got to lower the dose sooner rather than later. And a reasonable percentage of individuals on the trials and also in our practice dose reduce and still get benefit. So I'd say, thinking that this is a marathon, this is not a sprint. I think it's really important that we do reduce the dose earlier rather than later, because otherwise all you're going to basically be getting is not great quality of life, which isn't the goal of this. I'll stop there, and Kathy, any sort of comments? You're on Belzutifan. How does this fit with what your perception is of the drug at this point in time?
Pretty much it. The side effects, the fatigue. Quality of life is an option. I mean, I know that's what people look at. I think it depends on, I've had 14 major surgeries. So, and probably had another one coming in 2 years. So I started the drug and everything is, I mean, I'm almost tumor free. So, and I'm not talking one or two, I'm talking 7 brain tumors, 3 spinal tumors, 2 eye tumors, and 3 kidney tumors. And they're almost all gone. And my every surgery got harder to get through. So when you're on surgery number 14, it kind of gets to the point of, oh my God, they're going to give me a drug and all it's going to do is make me tired. Wow. I'm happy with that one. So it depends. If I was 20 years old, still trying to work, still trying to have a family, that's a whole different story. I'm on disability. So I can take a nap when I need to take a nap. But I still live a full life. I mean, I volunteer, I go, 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 go. But 2, 3 o'clock every afternoon, you may have to stop. But that's my choice.
Wonderful. Thanks for sharing. That's pretty amazing. And Seth is once again asking, is 80 milligrams the floor, but still beneficial? So no, we're seeing that I have some individuals who are on 40 milligrams and are still getting benefit. Everyone's different. That's one of the things that you learn is the metabolism of drugs is so variable in individuals. There are some people probably who need 200 milligrams, and there are some people who might need 20, just because your metabolism, the level of the drug in everybody's body is a little bit different. And not only that, it's the level of the drug, but it's also, the way it's interacting with the cells. I think this variability is we have to respect that, and we have to respect that everybody's an individual and everybody has to be treated differently. And I think at the end of the day, if you're not feeling good, you've got to lower the dose. And this is the key to success. And I can tell you, I have a number of individuals who are on lower doses and even on 40 who still are benefiting long term. And one last thing before we move on to Donika here is, and what Kathy mentioned is, why do we do this? We do this because we want to decrease the number of procedures. Kathy, you've had more than a dozen. You didn't want more. What we've seen is that in the trial, the number of procedures that people had in the 10 years leading up to starting the drug versus then in the 5 years that we have follow-up after starting the drug, the number of procedures dropped precipitously. So we are able to do that, which I think is really hugely beneficial for people. Now, we have, I think the longest person, the person has been on this longest now is like 7 years or so. So we don't have 50-year follow-up. We don't know what's going to happen 5, 10, 15, 20 years down the line. But at this point in time, we're not seeing any, by now we would have seen the weird and scary sort of side effects. We haven't seen any of that yet. So fingers crossed. Again, it's a good drug. We haven't cured VHL. This is, I think, a very important next step. And we have to, I think, not rest on our laurels. We have to be grateful. But we also, as a research community, and that's what I do, is we have to think about, okay, we've now finally got a thin edge of the wedge here. What do we do next? So I'll stop there. And I'm going to hand it over to Donika, who's going to talk about the amazing things she does.
Before I do have a quick question for you, Dr. Jonasch. I wonder if you could speak a little bit to the individuals that are maybe in families who have VHL. So they're maybe younger and might have a tumor or so, but they're not somebody who's had multiple tumors, and so they're interested in starting Belzutifan. What are some of the things that you guys talk about and considerations on when to start or how long to wait until they start?
Great point, Donika. So if I meet a 24-year-old individual who has one renal cell carcinoma that's like 2.9 centimeters in size, we're like, in the next year, something's going to have to be done about that tumor, or maybe even now, because it's getting close, and they've got nothing else, their central nervous system is fine and everything else is fine. I would actually recommend that individual get surgery. Because if you look in the looking glass, that individual will probably have a runway of maybe a decade of not needing another intervention. And that way, you have a choice A, surgery. Nobody loves surgery, but nowadays with robotic and minimally invasive and that, I mean, it's less bad. but that person might be in their mid-30s before they need to have the next thing done. That's 10 years of basically clear air. So I think that's not the person. A person, who has had more than a dozen surgeries, where you're like, I don't want another surgery, and I have a whole bunch of lesions in multiple organ systems right now where I'm going to need a whole bunch of other surgeries. That's the person that really will benefit from this drug, just to kind of bookend it here. A couple of quick other questions here. Does the time of day matter when you take Belzutifan? No, but I think, and then the next question, are there strategies that can help with fatigue? I think one thing that people have noticed, and Kathy, you can perhaps tell us more, and I'm stealing Donika's time here, is I suggest that people take it in the evening, because that way you can perhaps sleep off some of the side effects. Have you tried that, Kathy, and did that work for you?
Yeah, I take mine like 4 o'clock, like right when I'm eating, dinner time, because that way I don't forget to take it first. Because I have to take Zenpep to digest my food and other, so you just add it right in. I tried mornings, and no, you lose a lot of your day. It's definitely, to me, nighttime and sleep it off. So
Great. Excellent. Okay. With that, Donika, Kathy, any other questions for me?
Well, I did have one quick question. It's been in a conversation in a lot of places now. Lots of doctors have been recommending vacations from the drug, taking time off. There's been no study. So just curious what your thought is on that.
Yeah, I think taking breaks doesn't. So if you take a break, it's not going to break the utility of the drug. So we do see people who take a bit of time off and then they restart. Things might grow a little bit and then things will start shrinking again. So yes, I think you can do that. We don't have proof. We don't have major evidence that that's okay. But intuitively, based on anecdote, I think it's okay to take breaks. We just haven't validated that. And one other question here in the chat again, is it safe to use long term? As of now, our knowledge is yes. We haven't come up with we have not encountered new worrisome side effects after multiple years. So I think so far, so good. And the last question here is, how long does it take for a response? So I think that we're seeing that the median time to like a 30% shrinkage is sort of in the order of 8 months. But what we do see, I think already at 3 months, you might see a little bit of shrinkage, and then at 6 months, a little bit more, 9 months, a little bit more. And it's a linear thing. So unlike with some of these other agents that we're using, where we see, 90% of the benefit's going to be in the first 3 months, and then you're kind of like flatlining in terms of further benefit. Here, it's kind of like a little bit more, and a little bit more, a little bit more, a little bit more. And we're seeing that over years, things keep on getting small, especially in the hemangioblastomas. A little bit less so in the renal. The renal cell carcinomas might start plateauing. All right, now we need to move on to Donika.
Yeah, and I'll be brief, and hopefully if anyone has genetics questions, you guys are welcome to reach out to me. But just a little bit about genetic testing and genetic counseling in VHL. Certainly it's very important, especially as we begin to think about family members and expanding that testing to other at-risk relatives. But ultimately, genetic counseling helps individuals and families understand the risks associated with the disease, discuss the inheritance and the management options. Just make sure that you are meeting with the providers and the care team as needed. And we utilize family history for individuals who are undiagnosed based on their personal and family history to decide on genetic testing and advise on family planning, and then guide individuals towards the appropriate surveillance. And so ultimately, we just really want to get families the care that they need and get them plugged in, especially in this case where the community is so great, and being able to hear from different perspectives and kind of think through what best option is for them. VHL is autosomal dominant, and so of the 2 copies that we each have in every single gene, there has to be one pathogenic variant to have these symptoms and to cause the predisposition to these tumors and cancers. And so it's important for us to have the genetic testing to determine if we can identify a VHL pathogenic variant. And the testing is actually really great. So it's able to pick up about 90% of individuals who have a clinical diagnosis, and then can be in turn used for, again, Belzutifan or other treatment recommendations. We know that it's highly penetrant, and so somebody who has VHL is going to have a pretty high likelihood to develop one or multiple of these tumors. But we also know it has variable expressivity. So that means people, even within the same family, can have different ages of onset and different tumor developments. And that's really important because some people might think if they mirror, for example, what a relative might have had, maybe it was later onset, they might be less likely to abide by some of the guidelines. So always follow the guidelines that the providers give to you. Usually that's tailored based on your personal history and the information that we have. In genetic counseling, we also discuss inheritance. And so while most of the time this is inherited from a parent, from your mom or your dad, there's the case of a de novo, so a brand new mutation in some individuals that usually occurs very early in the embryo's development. That's important to identify, mostly to determine who else is at risk for genetic testing to have VHL as well. In the case where we expect it's inherited from mom or dad, we usually recommend cascade testing. That means testing immediate relatives, so parents, for example, to determine parent of origin if it's coming from mom or dad's side. But we know that full first degree relatives, so siblings, children, and parents have a 50-50 chance to have VHL. And even in the case of de novo, we don't want to exclude testing for family members. It's important, particularly for the offspring, so the children of these individuals, to get tested because it could still get passed down. And then there are specific variants within the gene, and sometimes these encompass different changes within the DNA which affect the VHL protein and its function. And you might have seen different types of VHL, like subtypes. So sometimes it helps us better understand possibly what expectations of tumors might develop. So if we might expect somebody to have a pheochromocytoma, but those aren't always consistent. And so again, just having your care based on your clinical presentation and the screening guidelines is always most important. And then another thing I wanted to mention and kind of touch on is negative genetic testing. So for individuals who have clinical features of VHL and undergo genetic testing that's negative, this is maybe about 5 to 10% of individuals. Typically, this can be explained either by something like mosaicism, where they might have a VHL pathogenic variant in some parts of their body, but maybe not their whole body. And we'll never really know, is that 50%? Is it just certain organs? But it could affect the likelihood of certain tumors depending on where the VHL variant is present. The other thing that we like to look at from a genetics perspective is if they tested negative for VHL, we want to assess if there's something else that they might overlap with in terms of their physical features and their clinical presentation. So should we be looking at other predisposition syndromes that might also explain some of the features that they have? So if they present to our clinic with renal cell carcinoma and maybe have one of the other VHL symptoms, could those just be overlapping and truly they have something else going on? So sometimes we utilize tumor testing or other clinical recommendations to think about genetic testing in those individuals. And then lastly, just wanted to touch on family testing. Again, a lot of people who know they have VHL are focused, of course, on their care. And we just want to make sure that all of the at-risk relatives also get genetic testing. So I mentioned that would be, of course, the first degree relatives, and then we want to share that information with other family members as well. The biggest thing there that I can recommend is sharing a copy of your genetic testing report if you're comfortable with that, so that family members can also have genetic testing of the same VHL variant. And nowadays we're all kind of spread out. So you might have, you might be in Florida, but have a family member that's in California. So they have different ways of finding genetic counselors or finding care for testing as well. One of the easiest ways to do that is if they visit nsgc.org. That has a specific link where you can put in your zip code, find a genetic counselor so that family members, even if they're not local, can have genetic testing as well. And then just a little bit more about genetic counseling. If you are connected with a genetic counselor and you have questions or you want to get connected, that's one of our primary responsibilities, is just to guide patients, helping them find support and resources if and when they're ready, and just get them connected. And so we're really fortunate to have the VHL Alliance, which has an abundance of patient education and ways to connect. And so hopefully people are taking advantage of that. I think just even having Kathy here talk about her experiences helps others better understand maybe what different pathways there are and what considerations to think about. So just would encourage everybody to reach out either to your care team, your genetic counselors, or if you want to get more involved and touch base with other patients. I think there was a chat question. Okay, with regards to mosaicism, are there any emerging testing? So there's not really great options with mosaicism because the solution would be testing various organ sources. And so with things like if you're undergoing surgery for kidney cancer, then you might be already having the pathology for the kidney cancer, and it's not uncommon to have a VHL variant identified when you have kidney cancer. But otherwise, it would require biopsies of different parts of the body to determine where a VHL variant is present. And that's not very conducive, or we're not able to do that. So there's not really great genetic testing. The labs that we order germline genetic testing from, so testing to assess the DNA that you were born with, they sometimes, if they find like a VHL variant, they'll estimate the approximate amount of VHL that's present. And so sometimes that can make us be more suspicious for mosaicism, but it still can't really confirm it. So then sometimes another option would be taking a different sample. So like doing a skin punch biopsy to determine if it's present in another sample that's not, it's a little bit easier to have that type of procedure.
Kathy, do you have any questions for Donika?
No, I mean, my whole family I'm the only one tested positive, and yet they're clinically diagnosed, is what's happened. So they keep saying that they're mosaics, but yeah, it makes it difficult when you have people having brain tumors removed, and yet they were told they did not genetically have the disease. It's been an interesting road for the family seeing that. So I think there needs to be more discussion about what it means to be that, because if your family has it, and somebody in your family has it and you're having a hemangioblastoma removed, probably have the disease, and yet we don't talk a lot about it. I don't think it's that high a percent.
Yeah, that seems like a more unusual situation to have somebody in a family who already has a known variant and then have others who test true negatives have the presentation. I feel like that's not very common at all. So maybe to learn more about that.
Yeah, I guess goes to show that we don't know everything about the disease.
Yeah.
Donika, a question for you is if an individual with VHL has kids, how early, and they have kids basically the old-fashioned way without any sort of pre-implantation genetics, how early should they be testing their kids?
So typically, because the manifestations start at 1 or even younger, they could get tested pretty early, as early as birth, because that's when the management guidelines begin. There, of course, is, I know you mentioned PGT, so before conceiving, if you know that there's VHL present in the family, there's options to have genetic testing in that route. But yeah, typically we recommend testing for young children just so that they can begin screening if they test positive.
And one of the questions I was asked in one of our genetic sessions was whether or not there's any qualitative difference in whether you use a saliva test or a blood test or anything like that. Does it make a difference?
That's a good question. That comes up a lot. So if we can pass the qualitative control, then no, we expect the same results from blood and saliva. The only difference is with saliva, you're the one who's submitting the sample. And so you're the one who's making sure that there's not contaminants. So if you eat or drink too close, then that can affect them being able to extract the DNA. Or if you don't fill it up in the tube to the line that it's expected to be at, then they don't have enough DNA. And those two barriers are usually excluded when you have blood. And so there's not really a risk for having contaminants or insufficient amount. But to answer the question, if they can get past the quality control and they can extract the DNA, we anticipate the same results from both samples.
Great, thanks. I'm going to quickly answer these two other questions and we'll move on to Kathy. So one question about whether tacrolimus and azathioprine and valproate might interact with belzutifan. So I don't know the answer to that question, but this is something that there are online tools that can be used by pharmacy to look at whether or not there are interactions. And the key interactions here are some drugs will change the metabolic processes in the liver, will speed it up or slow it down, or interact or compete for the same pathways. And these are the sorts of things that you need to look at. So this is a good question. I don't have the answer for that question, but it should be verified, especially these drugs often are drugs that may actually interact with some of these CYP pathways. Next question, is there any reluctance to give belzutifan to a patient who's already had systemic therapy? No, I mean, I have a number of individuals who were on, sunitinib or pazopanib for quite some time, and then I basically segued them into belzutifan, and they were actually quite happy about it and did quite well. So I don't think there's any doesn't look like that necessarily engenders resistance in everyone. So I think it's reasonable. And then are there any other drugs in the pipeline? I mean, there are other drugs of the same type, but I have to be honest right now, I think now that, the glow is starting to sort of, fade off a little bit of like, oh, this is so great, we have a drug. And we now really need to sit down and buckle down and say, all right, this isn't good enough. We need to do better. And there isn't anything that I would say right now other than, we talk about CRISPR, gene therapy, and things like that. I mean, there's obviously things we have to think about moving forward, and we need to, as a community, make sure that better things happen. On to you, Kathy.
Okay, well, I'll just be quick about this. Like you all heard, I've been through a lot with this disease and all the experience. But I guess the main thing I wanted to talk about is some of the blocks that we run into as a patient. I always say you should be your own self-advocate, especially if you're not at one of the clinical centers. You should have the book that the VHL Alliance puts out that tells you the basics. You should be going to your doctors and telling them this is everything. Local doctors, not clinics. The clinics will know what to do with it. And if you don't know where the clinics are, again, the VHL Alliance website can tell you where the closest clinic is for you. But the big hardest part about being your own self-advocate is we're not medical doctors. We have not been to medical schools, and medical reports are not written in a language we understand. Figuring out a way to get your doctor to talk to you on your level. I go to the National Institute of Health, so I have a group of doctors there. Then I have a group of doctors here that back home that the constant conversations. And I get a medical report and I get my phone and I Google every third word. And I would love somebody in this world to create the AI solution that translates my medical reports to English. It is my personal goal. I bring it up everywhere. Somebody's got to learn it. They have tried. So far, AI has not been successful. But learning to read those medical reports. And when you first get diagnosed, like you said, you may have one tumor or one organ involved. I had all organs involved except one. So right from the beginning, I had to learn to educate. I'm on Facebook. I talk to people on there. If I find patients, I do volunteer work to help you, because we need more and more of the patients to become the experts. Because honestly, I've even been to my clinical doctors who will say, we're seeing something in your liver, but we're kidney doctors. And then leave me hanging. I mean, luckily they didn't. They brought in a liver doctor and we had the whole conversation. It is an amazing disease because of the 10 organs or more. I don't know if they're studying to look at the other organs like the thyroid and bring them in too, so that we could I'm sure there's more organs involved. We're running out of organs, but I'm sure there's more organs involved in this disease. And it's been quite the education. But on the other hand, I always tell people, I had one surgery where they had to undo the tumor off my facial nerve. And what I got out of it, every morning they said, make sure you smile and make sure you're even. And what a difference that makes you look at life. Every morning to this day, it's been 20 years now, I still smile every morning to make sure my smile is even. but it also makes me feel better. So the social side of dealing with this, keeping happy, and Belzutifan unfortunately makes you tired, and maybe you aren't going to get out more. Find a way, get out more, be out and with the world and try, because everybody has something. I mean, it really comes down to that, and just try to maintain your happiness and make that smile every morning, and you'll get through it all, because I've been through everything that this disease can throw at me, and I'm running out of organs for them to remove, though. So, which hopefully, I mean, I don't know. Are they continuing to advance? I mean, 30 years, we went from full open kidney to robotic kidney to now a drug that makes the tumors go away, plus all the other things they can do to our kidneys. But hopefully they're continuing looking. I mean, I hope the drug doesn't stop them from looking at other surgeries and other techniques so that it isn't so invasive. Because I mean, I don't have a pancreas. It's amazing how much that changes your life. So, but that's all I have. So make it easier to read our reports so we can discuss them and make things that make it so it's not so hard on our bodies, so we can just keep going. So,
Well, thanks for that. And your spirit is amazing, considering all of the things that you've been through. And you did touch on it a little bit, but I think one of the things that I think we in the medical community are doing a really bad job of is really sort of acknowledging and recognizing the sort of emotional stress, the anxiety that is associated with living with VHL. What would your 2 or 3 top tips be to make that easier? And you said you were told to smile, and I think
well, every
that
single
mere
morning.
act might make a difference. But what
But it
else?
was for
What else?
medical. That was
Yeah.
for a medical reason I was supposed to do
Right.
that, but it did improve my attitude. Um, my biggest thing is, and I mean, and everybody handles the disease different. I have a week, I always call it my week of torture. I have a week of torture, including seeing the doctors, discussing everything. And I'm done for hopefully a year, but lately it's been 6 months. I guess 6 months, and I don't think about it. I mean, we always call it, put it away. You put the VHL away I mean, obviously we're all a little paranoid with this disease, because if you get a headache but you do have to learn. After 30 years, I've lost a lot of the paranoia. I can just put it away and say, oh, this is just allergies. I think that's a big aspect of it. To me, because I don't working was my savior when I was going through the worst of it, because I had to put it away and go to work. I socialized, I was amongst people, and I am not just VHL, I'm this other. So learning to do that, and it's not easy. Now I do volunteer work. I do lots and lots of volunteer work, and I don't let anything go. I get a pain, I go do physical therapy. I go, because you don't want to let anything get bad. You don't want anything to go bad. And I don't know about anybody else's disease, but my belief, everything wrong with me is related to VHL. Everything. I mean, I've got pain in my hip. Turns out it's because I've had eight or nine surgeries on my abdominal. So I don't have any abdominal muscles, which has affected my back, which has affected my hip. So in the long roundabout way, we have to remember that. And don't drop anything. You gotta be, like I say, your own self-advocate. Do volunteer work or something so that you have time, that you're not totally focusing on yourself and this disease. And then I think the last part is make yourself happy. Because I do. I mean, people are always like, how do you deal with all that? And I'm like, well, I deal with all that or I wouldn't have been here. So I didn't have much. I mean, I lost hearing. I had eye problems in my teens. I wasn't diagnosed till I was 31. So that's why I had so much wrong by the time I got diagnosed. So, and I've also learned, I talk to if I have to switch to a new doctor, I interview them. Because if they don't have the same personality or the energy that I have, we aren't going to make it. And I'm going to get frustrated. They have to understand locally, I know more than they will ever know. about this disease. You know, they might know the words. I actually know what it means. And they know. So they have to be able to deal with that. And they got to deal. I'm going to ask every question there is when I read my medical reports. And
Yeah. Kathy, we really appreciate your perspective. There's a lot to learn from your story and your background. And I know you talked a little bit about the medical reports, but I think the fact that you know so much about VHL and everything you've had to learn, it's almost like you've learned a new language anyway. So just give yourself grace for not being able to decipher everything on that medical report just yet. I do wonder, just in the last little bit that we have, you talked a little bit about not only advocating for yourself and getting your physicians connected. How would you recommend somebody who's a little bit newer to get connected, whether that be through the VHL Alliance, if they're a little bit apprehensive to just jump right in and maybe attend meetings? Do you have any advice there?
Well, definitely the Alliance is helpful. It's hard to say this, but I have said it to people. Sometimes you might have to go bankrupt to travel to get to the right doctors. Unfortunately, there is nobody in Wyoming, the entire state, no matter how small we are, there is nobody here that is an expert in this disease. And if you want to survive, you need to go to, at least to start out with, you need to get to an expert. You need somebody. You know, when I was first diagnosed, I had tumors all over, and they sat down and discussed which was the priority, which surgeries first. That I don't know if doctors that don't deal with this disease could do that. I mean, that's a major, major thing. So, like I said, you need, the first thing I would do if I got diagnosed is I'd download the book and read it completely, and then I'd go make my primary doctor read it. Then from there, it's finding the right doc. It's amazing when you talk to other patients who is their advocate in the medical world. A lot of it's newer. Geneticists, if you're newer. If you're like me, long term, you didn't really exist much back then. And mine was a primary, and she actually was a PA, not a doctor, but she knew everybody. She knew every doctor in town. She knew everything. I guess it depends on what's wrong with you. It might be a neurologist, but you've got to find a doctor that's willing, and don't think it has to be an oncologist. I never had an oncologist until I moved to Wyoming. You know, you find the doctor that's willing to fight for you. That's what it comes down to. And you really need to go to a clinic. One of our clinics, like I said, they're all listed online, and they are trained in the disease, and they have the multiple aspects, all the different doctors we need. I mean, it's not one doctor we have to have, and to try to get your own group together. And if you do it yourself, you're probably going to be seeing doctors every week for the year.
Right.
You know, and if you go to a clinic, it's a good chance you might be able to see them all in 1 week. And one and done is how it's hard. As I always say, it's the week of torture. It's every scan out there. And because I'm in a research place, it's more than what you would even probably have done at a regular clinic. Because the NIH is doing studies, and they want more pieces and more more scans and more parts of you to help with the study. And it's a decision you make.
Yeah. Well, thank you. That's really great advice. I appreciate that.
Well, thank you, Kathy. That was amazing. Thank you, Donika. Well, thank you, VHL Alliance. You know, we've been talking about them a lot. I mean, they've really, I think, like I said, you know, I think two important things happened in 1993. One was the gene was discovered. Number two was that the VHL Alliance was formed. And I don't know which one's more important. So I hand it back over to our moderator here from i3 Health. And thank you very much.
Yes. Thank you so much, Dr. Jonasch, and thank you so much, Donika and Kathy, for such a thoughtful and informative discussion today. It was so wonderful to hear all of your insights on navigating the spectrum of VHL care and helping to raise awareness during this VHL Awareness Month. And thank you to the audience for tuning in today and asking such thoughtful questions. Be sure to subscribe to the Onc Data YouTube channel and visit the VHL Alliance website to learn more. So thank you again to everybody for such a fantastic conversation tonight, and have a great rest of the night.
Thank you.